thank you all for joining us for Grand Rounds. Today we have a 2-for-1 special. Dr. Jackie Adams and Dr. Ritu Bhatnagar joining us to present together. So Dr. Bhatnagar is a clinical associate professor in the Department of Psychiatry here at UW, where she's a specialist in addiction medicine. She's co-director of the New Start program here at Meriter, so some of you may know her from that. In addition to directing the Addiction Medicine Fellowship, she has developed training programs for primary care providers in buprenorphine. She is president of the Wisconsin Society of Addiction Medicine and volunteers for various organizations in Dane County to address substance use and mental health. Dr. Adams is an assistant professor in maternal fetal medicine here, joining our department after finishing fellowship here 2 years ago. She has been actively involved in the treatment of substance use disorders in pregnancy. She is the founder of Fresh Beginnings, a community program for women with substance use disorders and pregnancy. She has numerous awards for teaching and is actively involved in clinical research, as I think any of us on labor floor know. Please join me in welcoming both of them this morning.
Hi, everybody. Can everybody hear me okay? Yeah. All right, good. So thank you for having us. We've done kind of a couple different versions of this talk, but this seemed very timely, just kind of with the changing political landscape that I think we're all very well aware of. Our goal today is to talk a little bit about pregnancy and substance use. When I thought about this talk, I was like, if I were an obstetrician, what I would want to know. So sort of the theme we're going for is a pregnant woman walks into your office, what do you do now? And that's what I want you to kind of keep in mind throughout this talk. We don't have any disclosures. If you remember Ross Harrison, he once said, no one's paid me for my opinion yet. And I thought that was the best disclosure I've ever heard my entire life. So I use that every time. Our objectives are pretty broad, and so we're going to try and speed through things so we have time for questions. But in essence, we want to talk about medications for addiction treatment in pregnancy, look at the use of sensitive language and treating patients as a whole. And then finally, and perhaps most importantly, talk about legal ramifications that maybe we don't always think about. And with that, I'm going to turn it over to Ritu.
Okay, I guess we're doing the mouse. All right, we're not used to doing these in-person presentations anymore, so pardon the adjustment here. But so this is a graph I've put together actually based from the DHS website here for Wisconsin, and this shows the drug overdose deaths between 2000 and 2020. And what you can really see here is this is all drug overdose deaths, and then by opioids, and then other substances. Really what I'm here to point out today is what this trend that we've seen starting about 2015, where we've got the synthetic opioids entering the scene and really just increasing the mortality that we've seen from drug overdose deaths specifically for this. We're now entering sort of the beyond the prescription opioids, the heroin, and now we've got fentanyl, but we've also got polydrug that we're looking at. So this is a really concerning, unfortunately, and concerning trend. And it is a trend that is mirrored nationally as well. So if we are looking at this from a population standpoint, this is concerning in and of itself. In the world of OB, if we're looking at this from a what happens for pregnancy-associated mortality, we see this, this is from 2007 to 2016, that there's been an increase overall in pregnancy-associated mortality during this time period, but more specifically and disproportionately for non-Hispanic Black women that we've seen this. And when we look at, however, from opioid-related causes specifically, we see that there's been a disproportionate increase in actually a doubling for non-Hispanic white women, and from the same database. This was looking at Medicaid data nationally. And I really think this is, to me, emblematic of a lot of other social forces that are at play in the midst of all of this, that has changed the dynamic of the conversation some as well, but also has really highlighted that the substance use during pregnancy and related causes, particularly from a mortality piece, are becoming significant enough that it warrants these kinds of discussions that we're having here today to really focus on what you're going to be seeing in your offices and in treatment. So this is from a mortality piece. What I want to also look at are the people who are alive and coming to your offices. And that's where we see some of these statistics, which are also very noteworthy and important for you to keep in mind, that the women who are of childbearing age, more than 70% of all women with opioid use disorder fall within that category. So if you're not thinking about this when you're seeing somebody or screening for it, we're missing some information here, especially because women are reporting, and this is based on 2012 data, which is unfortunately the most recent review of this sort of information from the National Survey on Drug Use and Health, which is, it's a really wonderful compilation of this information, but has looked at this and said there's illicit drug use in the past 30 days, 4% of women are reporting this, and that's reported. So in terms of what's in addition to that, and 1% of pregnant women are reporting non-medical use of opioid-containing pain medication. The point of all of this is, yeah, these are numbers, these are statistics, but what does this actually look like when you are starting to see somebody? And part of what I'm wanting to do today is have us not just think about the statistics and the numbers, but the people that are actually behind these numbers and statistics. So if this is a startling image, and I'm purposely bringing it here today forward to have people reflect and think about, what does this image really, what does this bring up for you? And unless we are aware of what we are bringing into the room and into the interaction, we are not going to be able to be as effective. So hang on to that reflection of how that makes you feel as we continue through the presentation. The most important thing for us to recognize, I think, as providers, as we're going into a room, is our own biases that come into a situation like this. The piece that I want to help ground us in this discussion is, when you are working with somebody with a substance use disorder, if you think of it with the definition that's listed here, this is the ASAM quality, the American Society of Addiction Medicine quality practice definition of addiction. If you think of it as a treatable chronic medical disease that's multifactorial here, involving complex interactions and including the biology, the genetics, the environment, individualized experiences, it allows you to have a little bit more of an understanding that this is beyond just the behaviors that you might be getting called about. This is really a much bigger issue here for the woman as well as for society. So if we can think about this definition and think about it through as the history of the person that got them there, and allow us to really connect with that person on a human level, as opposed to just something to take care of that way. So that helps us think about it from a trauma-informed care approach. And this is these are some other statistics to think about and keep in mind, that if the woman has endured sexual abuse as a child, they're 6 times more likely to have opioid addiction, 4 times more likely to have alcohol addiction. These are things that are often missed as we are gathering history. And I think from my perspective, when I know that there is a history of trauma for people, it changes how I approach them and talk to them. And it's something that the trauma-informed approach in the words and the vocabulary that you use with people can also either perpetuate the stigma that's associated with addiction, or it can help dismantle it. And so this is a very quick primer on words to use, and there's much more comprehensive information. All of what we're going to be covering, in fact, are pieces of this that are probably an hour-long lecture on each of these topics, but we're doing this overview on purpose here to kind of get some of the awareness raised about what the language that you're using and how that will impact both your care with the woman, but also how your attitude and your team's attitude can impact the interaction that you're having. So for instance, if you say the person who uses a substance instead of addict or abuser or sometimes junkie or words that we hear, is because it's person first language to refer to that individual. So for instance, also not currently using drugs instead of got clean, because that implies that using is equivalent to somebody being dirty. Similarly with urine, showed the presence of, as opposed to the word dirty again. And that really helps to remind people when you're talking to them and your team as well. You're really setting the tone that we are working with an individual with a treatable chronic medical disease, not behaviors, not a moral failing. So it's just a way to orient yourself as you go through, not to make you hyper conscious about the words you're using, but just to help you think through what does make sense from thinking about the individual as a person. So if we now look at an individual case here, we have Jean here who will help us ground thinking through the rest of our discussion of how we can manage this. So she's a 23-year-old, Gravida 2, Para 1, with confirmed pregnancy, and she has one child at home. She's here for a new OB visit scheduled at 13 weeks. She does have a history of about a year of heroin use that she switched after using prescription opioids for pain. And she's concerned now about the effect of her use on her pregnancy. She wants to help and she wants to figure out what to do. So in thinking through this, we want to pause and say, what are our options for this woman and this individual as she's working with us? How do we help her think through what the options are? Well, we know that there are medications, which is why we're here. This is part of this is medications for opioid use disorder in pregnancy. We know that there are benefits to them. This is also going to be an overview of the medications because the residents apparently are going to get an hour-long talk, I found out. So not too much I guess in the future here. And so I don't want to spend a whole lot of time on the specifics of the medications, but I want to highlight that there are significant benefits that have been known for and shown for use in pregnancy, really working to reduce the risky behaviors and to improve the quality of life both during and after the pregnancy. And it's really based on the premise that using medications to stabilize withdrawal during pregnancy not only reduces the complications during pregnancy, it also increases the birth weight, it increases the retention in treatment. It will help treat the urges and cravings, and ultimately we're just trying to minimize those episodes of withdrawal which lead to those complications. So we know there are risks of treatment of medications, but if the woman is going to continue to use substances during treatment, during her pregnancy, it is much better for her to use medications that we know can stabilize all of these, as opposed to not having medication and having to encounter withdrawal and use that as the reason to just continue the cycle of use. So there are risks of neonatal abstinence syndrome or opioid withdrawal syndrome. And we know that drugs with longer half-life do have that lower association with NAS and NOWS. And ultimately the point is that is treatable. So that is what we're looking at, to see that the medications themselves, they do have a role and a very significant one. Which medications? There's methadone that's available to us. It's the best studied, has the most evidence for long-term effects. For the longest time, is considered just the gold standard. This is what we use. People were concerned that there are cognitive effects for children exposed in utero, but studies have looked at that recently, and there's lots of confounding factors, obviously. But in terms of looking at the cognitive changes, up to 5 years of follow-up did not show any significant difference from children who were not exposed in utero. So they are improved outcomes for the woman up to 6 months after delivery. If the woman is stable on methadone, what that tells us, when she starts her pregnancy, you want to continue her through pregnancy with methadone. The dose may need to be increased because of the increased volume of pregnancy, and often there's split dosing that's required. Buprenorphine is another medication. I'm not sure if people are familiar with it at this point. I certainly hope that we're learning more about this in medical school and training. So it is a partial agonist that is has been shown and studied. This is in 2010 now. It's hard to think about. This was 12 years ago that really looked at the use of buprenorphine during pregnancy and showed that buprenorphine-exposed neonates required less treatment for neonatal abstinence syndrome, had shorter hospital stays, and less medication for treatment. One of the nice things about buprenorphine, it does not require daily office visits. There is sometimes considered a higher risk of diversion. The combined product, there's buprenorphine and naloxone. There's concern that the naloxone in there, which is the active ingredient in Narcan, could, if it's injected, precipitate withdrawal, or via the placenta cause withdrawal. As really the placental piece of it in particular has not been shown to be as much of a concern as it was a theoretical concern. So the mono product with buprenorphine only is not available in some states at all by Medicaid. And so we have population-wide data to look at, and has showed us that that is actually a viable and acceptable outcome to use the combination product during pregnancy. So if we compare these two options, we can see that they're both available. The major difference between the two is the way in which the woman can access it. Methadone is really tightly regulated by federal statutes and really available only at the opioid treatment programs. So the woman has to go there every day between set hours, 5 to 11 a.m. usually. So you can imagine what that might do to your life if you had to do that every single day. And there's often, because with pregnancy, we want to have as consistent a level as possible. They're recommending twice daily dosing. So there are some complications there with having a take-home dose. With buprenorphine, it can be dispensed from the office space setting, and the dose may not need to be adjusted during pregnancy at all based on the pharmacokinetics there. There have been some changes recently with buprenorphine that I think will hopefully appeal to you all. Back when it was first made available in 2000, there were 8 hours of training that was needed, and there needed to be able to provide psychosocial services. This really felt like a big hurdle for a lot of providers to add that on in addition, and really perpetuated some of the stigma of treatment of opioid use disorder. So Congress through the years has extended prescribing to nurse practitioners, PAs, CRNAs, nurse midwives, and clinical nurse specialists. So that's a recent change that people may or may not be aware of, but it really increases access to care. The other thing that's happened during the pandemic is that because this felt to be a bigger hurdle, we've reduced the hurdle and made it something that people can hopefully just incorporate more readily into their practice. If you're not planning on treating more than 30 people, you can just apply for this notification of intent, which is a couple of clicks on a website. Instead of going through a training and having to do all of this, you can still get the information, and absolutely encourage you to be familiar with the medication and how it's used. But in terms of the regulatory burden, it has been reduced. So that means also a lower hurdle for you to prescribe. So with all of that preamble, I'm going to now turn this over to Dr. Adams to talk us through what we do with the case and how to manage it.
Great. So we're going to come back to Jean at the end and kind of go through everything, but I just want to give you a primer of management of opioid use disorder in pregnancy. One question that I think always comes up is, what about withdrawal? This has been a hot topic for many years and very much depends on who you talk to. Sort of the long and short of it is withdrawal has not been recommended in the past. And by withdrawal, I mean completely stopping any MOUD or any opioid containing medications. And the reason for that really isn't what people think. I think people think it's because we want women in an MOUD program so that we can kind of control it. And we do want that. It's all about harm reduction. But the data that we have saying that opioid use disorder in pregnancy is dangerous is really from when people were in this chronic relapse and withdrawal cycle. So that's what's dangerous. And the reason withdrawal is not recommended is because the risk of relapse is so high if you're not in an MOUD program. And some studies, it approaches 75% risk of relapse. And so the reason we encourage women not to withdraw from all substances and use MOUD is really to avoid that chronic relapse and withdrawal cycle. Now, that being said, there are some people with really high populations with this patient population in really high numbers that do undertake withdrawal with their patients, usually in a controlled environment. If there's an inpatient rehab program that they can be in, or an intensive outpatient program, something like that. So this is very much a personal decision for the patient and what they feel that they're capable of in their past history and all of those things. Oh, roll. Okay. Sorry, we'll figure this out eventually. So what do we do for any pregnant patient with substance use disorder? And the key is really I think about it in sort of different segments of their pregnancy. So pregnancy is a really unique window of time when you think about it. A lot of women that never had health insurance before have health insurance. They have access to resources. They can get rides to doctor's appointments. They can kind of follow up on chronic medical problems that maybe they couldn't before. So we should always be thinking, in my mind, how can we maximize this pregnancy and how can we get people the treatment they need? So I really think about this. Everything we do is multi-centered care. So we want to look for things like housing instability, poor dental hygiene, poor nutrition, screening for hepatitis C, making sure that people are immunized against hepatitis B. If they've been incarcerated in the past, screening for tuberculosis. And then let's not forget counseling about coexisting substance use and coexisting tobacco use. A lot of the data about overdose and mortality, one of the biggest leading causes is polysubstance abuse. And so I think we can kind of get lost in the weeds dealing with one problem at a time, but we really need to be looking at other medications too. And then I also think tobacco use really gets overlooked in this patient population. It seems like kind of the lesser of the evils, but we'll talk about this a little bit in resident lecture today. It's one of the single most important modifiable risk factors for NAS and NOWS. In some patients, especially in preterm babies, it can almost double your risk of NAS and NOWS if you have coexisting nicotine use. So I always tell patients, hey, you're doing great. You're in a treatment program. You're making all these positive changes. Even if you can cut back on your smoking or get rid of it, then it can make a world of difference. Intrapartum care, I think we're all pretty familiar with this. You know, when you look up what to do, especially with buprenorphine, you're going to get all this conflicting data about minor surgeries versus major surgeries versus all of these things. The general consensus between SAMHSA, ACOG, and ASRA is that you continue MOUD during labor and delivery and postpartum. The reason for that is because A, they can help control pain in some reasonable degree, and B, the risk again of relapse if you stop medication suddenly. Also, you want to make sure that you're doing this when they're postpartum as well, and you need to think about dose adjustments and things kind of as they leave the hospital. And then also working with your anesthesiologist while patients are in labor. Maybe they need an early epidural. Maybe they've had bad experiences in the past. We should be talking to them about these things. Another thing that I think we forget about is that some of the medications we use on labor and delivery are actually partial antagonists. So things like Stadol and Nubane. If you've ever seen a patient in acute precipitated withdrawal from Nubane, I promise you won't forget it. I've seen it one time, and then we banned Nubane from my hospital. So just being aware of that, because maybe not every patient is going to reveal their opioid use to you. And so this is just something to keep in mind. As far as postpartum goes, and again, this data is from around 2017 to 2018. A lot of it comes out of Vermont, and a lot of it is kind of older, but you know, we get the general consensus that women that have opioid use disorder have higher pain scores than their peers, especially at vaginal delivery and C-section. Buprenorphine, we think, requires about 47% more narcotics. Methadone's thought to require about 70% more. I think we've all had patients that definitely fall outside this mold and sometimes need even 2 and 3 times the amount that we're used to giving. We're really, really lucky here in that our anesthesiologists are pretty flexible. We're really working on ways that we can maximize multimodal pain control in this patient population. When we first started rolling out preservative-free morphine and the neuraxial analgesia, these patients were excluded, but actually we're starting to roll this in because the risk of respiratory depression is much higher with oral medications and IV medications than it is with that. And then some other things have been tried, like clonidine in the epidural. or spinal. So to be continued on that. There's still just kind of a dearth of evidence on this. And so we're working on it. The other thing we're really lucky about is our pain pharmacy team. So if you ever have a complicated patient, you can call them and they'll help you make a pain plan. Sometimes it's as simple as if the patient's on methadone, we split it up into 3 times a day dosing instead of 2. We really work on maxing out their PO medications. We can also do things like tap blocks. That's a little bit less helpful with derm work because of the length of action, but those are all things that we can consider ahead of time. For postpartum care, it's really about follow-up. Again, we have a very short period of time sometimes. Maybe this patient's going to lose health insurance in 6 weeks. So there's easy things that you can do that you don't want to miss. As we mentioned, the coexisting mental health is very, very high in this patient population, especially postpartum depression. At least 40% of patients with substance use disorders in a survey reported postpartum depression, and that's just in a survey. So who knows what's actually happening. We also need to think about things like setting patients up with primary care. We'll talk about this a little bit more too, but every access clinic has a physician that'll treat hepatitis C in the family medicine department. And for complicated cases, GI is actually going to set aside some time every month where they can take those patients. So if we can get them into treatment while they still have health insurance coverage, then that's a really big thing that we can do to improve their future quality of life. The other great thing about access too is they also have I keep saying waiver trained. I just can't make myself stop. They can also be buprenorphine prescribers. And then as gynecologists, I think we really can't forget unintended pregnancy, especially with the current political climate. 50% of pregnancies in this country are unintended. This number approaches 86% in patients with substance use disorder, specifically opioid use disorder. So we want to make sure that we begin counseling early about patients and providing them with reliable birth control. But I have to put in a plug that reproductive coercion is real. So we should counsel and we should be appropriate, but we should make sure that we give patients a choice about their future reproductive plans. And then finally, I think this slide is really important, and sometimes I have to come back to this and ground myself in it, but the first year postpartum is really hard for anybody, but there is very good evidence that women with substance use disorders, particularly opioid use disorder, die more frequently the first year postpartum. The rate of overdose death is higher in the first year postpartum than it is the year before pregnancy or any trimester of pregnancy. As you can see here, MOUD mitigates that risk. So in orange, the rate is lower across all fields. And I think if we really stop and think about it, this is for a multitude of reasons. We, again, lose health insurance, maybe lose access to mental health, maybe fall out of an MOUD program. When our patients have a new baby at home and maybe don't have a good support system, and maybe they've actually used this as an opportunity for sobriety, then they use again and their risk of overdose is higher their first time using again. So I think it's really important that we do preventative counseling for this about patients. And we're seeing this trend in Wisconsin too. It's now becoming the highest risk factor for maternal death above vascular disease and heart disease. With that, I'm turning it over to you. Okay.
So we're shifting gears to talk a little bit more detail about the legal and ethical considerations in this population specifically. This is representative, I think, of the stigma that's associated with substance use disorder in pregnancy. These are the kinds of headlines that we've been seeing for a while. And it's very challenging for me to see that as an addiction psychiatrist because the characteristics that define addiction are impossible for an infant to display. The only things that we're seeing are withdrawal syndromes from the infant. And so that is what is treatable, and that is what we are trying to dismantle, is this approach to this. Unfortunately, because of these headlines, because of the social pressures and the stigma around it, we've come to understand that the laws that have been made have unfortunately been more towards punitive approaches as opposed to engaging women in treatment. So we see this nationally in 24 states and the District of Columbia is considered child abuse under civil child welfare statutes, and including Wisconsin, consider it grounds for civil commitment. So there are some that require professionals to report suspected prenatal drug use and also test for prenatal drug exposure. So this flies in the face and is in direct contradiction to what ACOG and many other medical bodies recommend, which is seeking the gynecologic care should not expose a woman to criminal or civil penalties, such as involuntary commitment, loss of custody of her children, or loss of housing. So you've got the medical bodies saying one thing, you've got the law saying something completely different. And there's a huge disconnect here of what, and then we as the providers are in the middle, and obviously the women and the families are absolutely caught in the middle of all of this. So in that context, and this is before I was even in medical school, this Act 292 was passed here in Wisconsin, which now known as the Cocaine Mom Law. But I don't know if people are aware of this. This is partly why we're having, it's like, I can't believe we're still having this discussion, but we are. And this is the words of the law are what we need to actually help explain, because it still stands. This is grounds for civil commitment. It added the term unborn child to Wisconsin child abuse provisions, which defined the unborn child as the human being from the time of fertilization to the time of birth. So that's obviously before a lot of women even know that they are pregnant. And this is very, very challenging how this plays out in day-to-day life and in the lives of your patients. This is what we need to really ground ourselves in and look at what does the law actually say and how do we help understand our role in that. So that's the context of the next part of this discussion here today, that this, according to this act, the unborn children have certain basic needs, need to be free from physical harm due to the habitual lack of self-control of their expectant mothers. So if we just pause for a second and think about what does that mean? And to what level of absurdity could this be taken? If one wanted to, for instance, staying on your feet and working a whole lot of time, like, I don't know, residents do. How does this make sense in terms of the physical harm that's, we're working a lot. We are, if we have gestational diabetes and you're eating a lot of sugary foods, this could fall under that same category too. And the thing that I'm pointing out is that the way that the law is phrased does not make a whole lot of sense. But the amendments to it that I want to also highlight is that it frees but does not mandate health professionals to disclose confidential information when exam of the expectant mother of an abused unborn child creates reasonable ground for an opinion. The emphasis on this is mine, by the way, because this is also where I'm highlighting the spaces for discretion on our part. What constitutes reasonable ground for an opinion that the physical injury inflicted caused by habitual lack of self-control in the use of these alcohol-controlled substances or controlled substance analogs. And if you think about the other implications of how this is being enforced and how it's being looked at, it's less often for alcohol, more often for these other substances. So there's some differential enforcement already that the medical system maybe looks at too. So the health professionals actually named in the law include the people you see here. So anybody associated with the care of this individual along the way can report this woman to essentially what ends up being is Child Protective Services. The Child Code amendments, these were codified in 1999 that allowed the state to take physical custody of a pregnant person for up to 48 hours until there's a hearing. And it assigns a lawyer to the embryo or fetus, but not for the pregnant person. It can force the person into treatment, psychiatric hospitals, or even jail. And hearsay evidence is permitted. So a lot of things that don't make a lot of sense in many other venues suddenly are being applied for this woman in this particular way. So the challenges that we see with this are really, the first question, is this legal? There are a lot of, there have been lawsuits brought about this. And in fact, the most famous one right now is there's a documentary about Tammy Lesher, who's in 2014. This is the specifics of her case. If you want to get yourself all wound up about this, you can watch the personhood documentary here. But it really just follows her story through. There have been other cases that have been brought up. Hers went all the way up to federal court. And it was actually deemed unconstitutional in 2017 by a federal court based on lack of substantive process, due process, First and Fourth Amendment violations. There were a lot of problems that were highlighted with the law, with the way that it was applied to her situation in particular. And it allowed this to become on a national level, really get some attention, but it also should allow us to know and reflect on the impact that the reporting can have on a woman's life. This is something when I started here at Meritor, I didn't know really a whole lot about this. And it was only in the last 6 years or so I started asking, what are we doing with this particular scenario? And I found out that we're reporting. We were reporting as just routine part of care. So this law, even though it has been deemed unconstitutional, it still stands because she had left the state, and the Seventh Circuit Court threw out the appeal based on the fact that she was no longer in the state. But nonetheless, the point stands that the substance of the ruling was neither addressed nor overturned. So because of that, it's still being enforced differentially across the state. And this to me is the real challenge here with what's happening with substance use disorder and pregnancy treatment in Wisconsin. And it is really affecting a lot of women. We may think this is not a big deal. 1,200 women approximately each year are investigated for this, and their lives can be turned upside down in terms of fearing if their loss of their custody of their children, the ones that are currently in their custody, as well as the one that's in utero. So this is it's a real concern, and it's really something that in light of what we are doing here at Meritor, we really looked at that. And I'm going to turn this over to Dr. Adams to see, how did we address this from a Meritor policy level?
So this has kind of gone back and forth, but kind of at a policy and procedural level, I shouldn't say this was 100% Ritu. I actually made quite a bit of leeway. And it used to be that the policy of an abuse of an unborn child just talked about basically the law. Now it's a little bit more specified to be in line with what the law actually says. So a mandated reporter may exercise their discretion in determining whether to report a suspicion of abuse of an unborn child. If a mandated reporter is considering reporting a suspicion, they are strongly encouraged to initiate a discussion with the patient and appropriate members of the team. So part of the reason I wanted to bring this up today is I've really, really been working in Fresh Beginnings, working with nursing staff, working with hospital administration. We all have to say, if you are going to make a report, let's have it be a discussion first. Because a lot of times, and you probably don't even know this, if your patient has a positive urine drug screen only, and it doesn't even have to have confirmatory testing, a positive urine drug screen can trigger a report to CPS, even without confirmatory testing, even without confirmatory meconium, cord blood, anything. And this can actually be in other counties, happens quite frequently, and women can be taken into custody for it. So I really want to emphasize, and legal really wants me to emphasize, that a mandated reporter, because of this, can make a report, and they don't need our permission, and we can't tell them not to. But we just need to be sure that we're sending a clear message that it's permissive reporting and not mandated reporting, and that's what we're doing for our patients. And you may be getting calls about this, right? Because now I've sort of volunteered all of you to be on my team with this and make sure if they say that this is what's happening, that we have a discussion with the patient, because I think we owe it to our patients to do that. And I think another important part of this is before you send a urine drug screen, making sure that you're getting patients' permission and talking through this as well. And so how does this affect screening and intervention? Coming back to that, ACOG does not recommend screening with urine drug screens. In a lot of places, I know in Ohio, we did this routinely because our rates were so high, and it wasn't the case in that state. And so this is what we did. But we really shouldn't be. We should be screening patients with brief interventions like the 5Ps, the 5Ps plus. Dr. McDonald is doing a really great job getting this program rolled out within the ACOG group, and hopefully soon to all UW groups, to ask these questions. And we also should be talking to patients before we do it. Another thing I really want to emphasize is that a urine drug screen is just that, it's a screen. It is not a confirmatory test. Many medications that we use routinely on labor and delivery and in obstetric care, even beta blockers, can cause false positive screens. And if that's never followed up with a confirmatory test, it can lead to life-changing consequences for patients. And as you can see, we're kind of setting you up here to see this tug of war we're all in, right? So for addiction treatment, our addiction medicine colleagues, they need urine drug screens that can help guide your treatment. We need to know what medications the patient's taking. If somebody's actively taking opioids, we don't want to give them an opioid antagonist. That's just common sense. And so we as obstetricians really need to think, do we need this urine drug screen? Do we need this testing to change our obstetric care? And so I guess what we're here to say is we don't want you to totally stop doing it. We just want you to think about the repercussions and how it could change your care. Because at the end of the day, we're all kind of fighting what's in the patient's best interest, what's in the best interest of the baby, what the state law actually says, and how we can all work together. Another conflict here is the conflict and the tug of war between the patients and the providers then. So patients want to get care. In Tammy Lesher's case, she wasn't even actually using substances. She was in recovery, but presented for help because she was concerned about use, and then she was taken into custody. And so we really have to be open to our patients and have discussions and make sure that we're treating them appropriately and not opening them up to legal action. It's been proven time and time again in states that have laws like this that making substance use disorders illegal does not prevent substance use disorders. It just leads to worse birth outcomes because women don't get care. That's not an opinion, that's a scientific fact. So what do we do for Jean? How can we work together? I think kind of the whole point of this talk is just to give you an idea how to approach this patient the next time it happens. So you are not a mandated reporter for positive toxicology. You are a permissive reporter. Make sure you talk to your treatment team, inpatient and outpatient. If a person is in recovery and let's say they need a urine drug screen because we're concerned or they're altered or something like that, that's a different story than just screening routinely with urine drug screens. And how do we work better with our patients? I think if we leave you with anything, it's just to try and think about the patient as a whole person and not about their substance use disorder. Most of these patients have been through life circumstances. Fortunately, none of us will ever understand. I also think that we need to talk about testing choices and implications more. I admit that I am guilty of saying, we're going to get a urine drug screen. That's fine, right? Like in cases before I knew this. And it's really not that simple. We need to be providing informed consent. And then again, a little bit more case specifics and to get down to the nuts and bolts. Do you need a urine drug screen? Will it change your care? If that's a question I ask myself a lot, the number one rule of medicine, right, is don't ask a question you don't want to know the answer to. So if it's not going to change your care, we shouldn't be screening with that. But if it is going to change your care and it's needed for treatment, then that's a conversation that you need to have. And then refer to an MOUD provider for this patient. We get this question a lot, outpatient versus inpatient. There's a very reasonably large body of data now that this can be done safely as an outpatient. And so what I like to do if a patient calls my clinic is ask about their insurance, and then there's whole lists of providers in town. If they've ever had an Access PCP, they can be referred straight back to Access to be put into with a buprenorphine provider. If they're interested in methadone, then you can look up the clinics that are reasonably close to them based on their insurance. I would say that this gets a little bit more controversial once they're of kind of a viable or in the third trimester because of that risk of relapse and withdrawal, especially in our community right now with the rates of fentanyl and the risk of precipitated withdrawal with fentanyl. And what other topics do we need to cover with Jean today? I would advocate that we need to talk to her about her mental health, talk to her about her smoking, talk to her about high risk behaviors. Harm reduction is kind of a higher level topic, right? Like it's been very recently that we've been open to things like needle exchange programs. And so I think for a lot of us, harm reduction isn't something that we think about every day or something that we're used to doing, but it should be. So maybe even there's a resource in town where patients can get free Narcan, free fentanyl testing strips, thanks to the new law change by Tony Evers. And so thinking about things like that, making sure her family members have Narcan. These are all things that we don't really think about on our day-to-day basis, but are really important and could potentially save your patient's life. And then finally, what else can you do? Oh, wait,
we've been working together on this topic for quite a while. The Society of Addiction Medicine, OB faculty, and the National Advocates for Pregnant Women, we've been really trying to figure out how to advocate for change. The challenge remains that even though the law is deemed unconstitutional, it still stands. And it's very much dependent on enforcement based on who is in the governor's office. And that is, it's a political hot topic. Nobody wants to touch this one. I get it. At the same time, we then need to figure out within what we have the capacity to change and look at, what is our role in this. And we've talked to the current Attorney General, the Department of Children and Family Services, and they are very much aligned with getting women to treatment. We know that getting women access to that prenatal care, that's critical. However, with the way that this is set up, if the woman is afraid that she's going to be reported and possibly lose her children, access to her children and her family, she's not going to come in to get treatment. They're very aware of that. And that's a very reasonable approach right now. We hope that that will continue. It's just something that regardless of who is there, what we need to then focus on is how can we provide the education to the providers about what the law specifics actually are and what are the consequences of either reporting or not reporting. We've talked to the National Association for Social Workers. The Wisconsin chapter has no awareness since the law has been enacted of any licensure action being taken for somebody to either report or not report on this topic. So the fact remains that it's permissive reporting. And that is the challenge as you are working with other care members of your team who may have received different information about what the law actually says and what their role is in that. So routinely just reporting doesn't make a lot of sense with this, because we are really trying to get women into treatment and not directed towards a punitive approach. So there's also other ways to get involved. We've talked about the National Advocates for Pregnant Women. We've talked about lobbying your senators. I know this is not the prime way that physicians usually get involved, but it's certainly an option that exists. Dr. Adams, did you have other sort of concluding pieces?
Yeah, so you can also visit the National Advocates for Pregnant Women's site. They have fact sheets for patients and for physicians about this, ways to get involved. They even have sometimes letter writing campaigns and things that we've been a part of. And then just to round all of this out, I want to bring it back to what's our goal as obstetricians and gynecologists. And hopefully, if we've told you anything today, it's that really every major medical association is on the same page, and that treatment of women with substance use disorders is the way, and that treating it as a moral weakness is wrong. And finally, criminally targeting women for chronic health conditions in pregnancy is medically and ethically inappropriate and reinforces societal stigmas. So it's really our role to be protectors of these patients, to make sure that we're treating them medically. And then, the first half of the talk, how do we treat them medically? And then the second half is really considering their life as a whole and as a whole person and their future well-being. Now with that, we will open it back up for questions.
Hi, Luther Gaston. I have a comment if nobody has a question.
Oh, go ahead, Dr. Gaston.
I was going to say that, particularly in the inner cities, that the fentanyl is finding its way into other drugs, almost all the other drugs, cocaine, marijuana, all kinds of stuff. So that, it's not just the typical heroin and oxycodone and this, that, and the other. Now fentanyl is finding its way into other stuff. And one of the things that we need to do is really to think out of the box like some other countries about legalization of drugs. Because the thing with it is that at least if we can get somebody with heroin that's not laced with fentanyl, we may prevent them from dying. Or cocaine that's not laced with fentanyl. Because the problem now is the issue of fentanyl getting into all kinds of drugs.
Yeah, that's a great point, Dr. Gasson. And I think we're still trying to figure out too, even when women come in for MOUD initiation, things like microdosing, if we're concerned for fentanyl. And the problem is it doesn't show up on standard UDSs too. There's special tests for it. So it's definitely something we're thinking about. There's a question in the audience just for those online.
Hopefully this is on. Yeah. This is Maggie, one of the residents. I had a question about what you think that informed consent discussion would actually look like when talking about getting a UDS with a patient. Cause it sounds like truly getting informed consent would involve saying this could be reported to Child Protective Services and could result in your child being taken away from you. And if I'm a patient and somebody tells me that, I personally wouldn't consent to it. So I'm just like trying to think about ways to actually get informed consent in that situation, or not, if the patient doesn't agree to it.
I feel like our talks are probably different because
But
you
I
need
don't-
it. Yeah.
So, I mean, because you're going to be, so the reason that we're deferring to each other a little bit is because from a treatment standpoint, that's where I get involved, is when the person has already said, hey, I have a concern and I need your help and I need treatment. So for me, at that point, that person has already accepted that they need the treatment, and as part of treatment, they're going to need the urine drug screening. But in the hospital, that's a different discussion altogether. So that's why I think, actually, I'm curious about how you would then frame that discussion to make that seem something that can be helpful and also has those risks. It's a very sensitive discussion and needs to be handled with that caution.
Yeah, so I don't know that you have to go down every rabbit hole of what could possibly happen, all of those things. I think my usual spiel, if I need it for a reason, let's say a patient comes in and they've say they're in a program, but we can't find any records or all that, and we're trying to figure out whether to restart their medications, even that's pretty infrequent. But I usually talk to them, hey, we need to send a urine drug screen. And I try to keep it open-ended, like, if we need to do this for your care, what will we find? And so, and I need you to be honest with me, because if it's going to be positive, that could open you up to legal concerns. And I don't want to do that. And I always tell them the reasons why I think I need to send it. And then basically just say, this is what I need, and kind of go through those things. And so I'd say it's actually pretty rare once we sit down and talk that patients say no. I would also say I very rarely do so, because unless it's really going to affect my care. So kind of the common argument is if the patient has an abruption, like, you should do a urine drug screen. We did that routinely in Ohio because we didn't have to worry about it. But at the end of the day, if it's positive, will it change what I do? Probably not. I'm still going to treat their abruption. And so I know that's a long-winded answer to say. I basically just I think it's really important to say why you need it, that there are potential repercussions, and the alternatives if you don't send it. Sure. There's one in the audience too.
I hope this is not a silly question, but I feel like since being a resident here, some instances that I've seen for patients on labor and delivery are patients who have a history of opioid use and are either in treatment or no longer using. And these are patients that are getting urine drug screens just because of their history of opioid use. I'm just wondering what your thoughts are on how to best advocate for these patients with regard to, not getting a urine drug screen if this is a past history, or those who we really should be screening.
I really think it's great noticing, and I think it really speaks to how do we decide to do screenings at all? Is it based on a universal screening standard, or is it based on some specific other factors that are directing you down that route? And I think that's it's really an important awareness to bring to this situation in this discussion. Do you, from people who are coming in, is everybody getting screened? And if they're not all getting screened, then I think that's a problem in and of itself. So that speaks to different level changes that could be made to look at.
Yeah, and I also think it's really important to note that if they're in an MOUD program and they appear to be stable and you don't have any concerns, that urine drug screen isn't going to help you, because a lot of the things that you're testing for aren't going to show up on it anyway. So I think the most important thing we can do is talk to the patient. And if people are thinking about ordering it, just say, how are we going to use this? Questions like that. So and I think Dr. Brown brought up a really good point. How do we screen? We really shouldn't be screening with UDSs. It should be through questions. And hopefully that'll get even better as we continue to roll this out sort of in prenatal care across the UW system too.
And then there's a question in here about St. Mary's policies as opposed to Meritor's policies. I'm not sure that St. Mary's has a policy on this.
I've never been there.
We have actually tried to talk with St. Mary's about treating opioid use disorder in pregnancy, and I think their practice appears to, at this point, be to send folks our way, because we have an approach to managing this. So question there.
I think it's a quick one. I think one of the times when I get approached about this a lot is actually like the NICU calling, and when the patient's in labor or getting admitted and being like, oh, you need to get this. So is it appropriate for me to just say, I don't actually think that my care will change whether or not I have this, and you can feel free to talk to the patient about it postpartum if you want to obtain consent from them at that time?
I think that's very appropriate. And to be totally honest with you, if they have suspicions or they're doing NAS or NAL scoring, they are going to send confirmatory testing from cord blood anyway.
And at that point, based on Wisconsin law, that there is no gray zone at
Right.
postpartum, right? So we're just talking the antepartum period. That's what we're talking about in this entire talk today, is about that antepartum period. There is much less wiggle room of trying to understand or figure out what happens postpartum with the way that the statutes are written.
What she means is if the baby has a positive screen from meconium, cord blood, or anything, then it does become mandated reporting because it's a minor. And so we won't even go there today, but that is out of our hands and we don't have any say in that.
So much.
Yeah. Thanks, everybody.